All right, our last program of the morning. We welcome you here from the Commonwealth of Pennsylvania, the Mental Hospital Seclusion and Restraint Reduction Program with Charles Curry and Stephen Karp. Thank you.
Thank you. The care of persons with the most serious mental illnesses has historically been a core function of government. Effective treatment and support now enable most people with mental illness to live productive lives in the community. But what does this mean, to live productive lives in the community? And when we speak of hope, when we speak of recovery, what do we mean by that? People in the mental health field grapple with that as well as the general public. I came across a quote which helped me clarify recovery for me, as well as I think it's a quote that can help clarify for the general public. It's from Douglas MacArthur. General MacArthur was not known, I believe, as a mental health advocate, but General MacArthur did speak to the general human condition when he said, in the central place of the heart, there's a recording chamber. So long as it receives a message of beauty, hope, cheer, and courage, so long are you young. When the wires are all down, and your heart is covered with the snow of pessimism and the ice of cynicism, then, and only then, does one grow old. If these words of MacArthur's are true, then the person with serious mental illness is truly an individual who, due to the distracting voices or devastating moods, the symptomatology of mental illness, is someone that is isolated, is someone who has all the wires down, and in many ways has grown old before their time. This then tells us that once treatment takes hold, once mental health psychotropic medications take effect, once the wires start to come up, we must then, in the system, do everything we can within our capacities to assure messages are sent to that central place of the heart. Messages which convey beauty, hope, cheer, and courage. For when those messages come through and ring true, they melt away the ice of cynicism. They melt away a glacier of despair. This then invites recovery. This then allows individuals to live more of a full life in the community. For the 4,000 Pennsylvanians served each year through the state mental hospital system, we strive to create innovative quality services that restore hope and expedite recovery. The State Mental Hospital Seclusion Restraint Reduction Initiative is one such innovation. For centuries, seclusion and restraint were considered essential tools for the control of aggressive and self-abusive behaviors in psychiatric hospitals. Yet, seclusion and restraint do not alleviate psychiatric symptoms. Their use of isolation and physical force simply increases patient suffering and can result in serious patient and staff injury, emotional trauma, and even death. Seclusion and restraint are not treatment. They reflect treatment failure. In 1997, Pennsylvania announced that its 9 mental hospitals would pursue the immediate reduction and ultimate elimination of seclusion and restraint. We began by developing a statewide data system that allows us to monitor the use of seclusion and restraint, to measure the impact of our efforts more clearly. We chose to make this data public, available to advocates, the media, and regulators. We know of no other system holding itself publicly accountable for its use of seclusion and restraint, and our data are now being used as a national benchmark. Dr. Karp, please describe the process.
We convened a group of hospital staff, including doctors and nurses, and led by a physician to develop new policies which would improve safety and promote reduction. Pennsylvania's policies exceed all national standards, including recently passed federal legislation. Under Pennsylvania's model, only physicians may order seclusion and restraint. Physicians must examine the patient within 30 minutes, and orders may not exceed 1 hour. Chemical restraints are prohibited. Patients and staff must be debriefed after every incident. And very importantly, we use the new generation antipsychotic drugs now prescribed for 85% of our patients to more effectively reduce these aggressive impulses.
These efforts worked. Since 1997, combined incidents of seclusion and restraint have been reduced by 74%, while hours have decreased by 96%. One hospital has been seclusion restraint free for 8 of the past 12 months. Most others are approaching zero use. There are skeptics who felt that increase in patient and staff injuries would occur, but there has been no increase in patient assault-related injury rates compared to the previous 4 years. This initiative has generated significant changes in the hospital culture. Our patients say staff listen harder and now actively engage them in the treatment process, rather than rely on physical coercion. As consumers have more say in treatment, their role is transformed from one of helplessness to one of partnership. This initiative has been cost neutral, requiring no new staff, no new equipment, and no new resources. Pennsylvania's Seclusion and Restraint initiative has been cited as a model by the National Alliance for Mentally Ill and other mental health advocates. In summary, seclusion and restraint are not essential features of psychiatric hospitalization. Our initiative provides safe, effective, and replicable strategies for reduction. We are honored by the validation of the Innovations in American Government program and hope that this recognition will help others succeed in making psychiatric care safer, more effective, and more humane. I'm pleased today that Grant Stevenson is in the audience, who is a former patient of Allentown State Hospital, and he saw this transformation take place. And I think of anyone in the room, he firsthand has an understanding of that. I'd like to ask Grant to stand.
Grant, thank you for joining us here today. Questions, Carl?
Do you see the reduction in seclusion and restraint as an end in itself or as a means to some further end?
I see it as a means to some further end.
And what is that?
I see it as a means of helping facilitate recovery, helping individuals while they're in our care in the state hospital understand what it's like to be in control of their life instead of being controlled by a system or by professionals. I think it helps them understand their own recovery, being in control and being in charge of their own illness management. Too often, historically, seclusion restraint was used out of staff convenience. It was used as just a way of life, and it was not unusual to monitor seclusion restraint and see incidents, and people review it and just kind of say, well, this is the way life should be. I think what we have found is as we get serious about recovery, as we get serious about enabling and empowering people to feel confident about themselves, we need to assure everything we do facilitates that recovery. 80% of the people in our state hospital systems are victims of trauma, typically physical or sexual types of trauma. For us to re-traumatize individuals by taking them down and tying them down or isolating them seems very counterproductive and has been in terms of facilitating the treatment process.
Ed Dorn.
I may have misunderstood you, Dr. Karp. I thought I heard as you were going through your presentation, you said basically instead of restraining people physically, we restrain them chemically.
No, chemical restraints are prohibited.
Okay, I
may have
misunderstood
not
that.
said that clearly. But.
Okay.
Lee Hamilton.
Are the results of the monitoring that you do public?
Yes, we make the data public. In fact, we're not aware of any other system that does make that public around seclusion and restraint. It has fostered, I would say, a healthy competition also among our hospitals in terms of everyone's being benchmarked and reviewed. It also has been very valuable to our advocates. I have to say that there were mental health advocates in our state who for years talked about seclusion restraint. We heard from our consumers that what it was like to be restrained and isolated, and that they felt that it was detrimental to their own being. So the fact that we're able to demonstrate through the data that we've drastically reduced it. In fact, it's at the point that JACO at their last review indicated that we no longer, for their purposes, need to monitor it because it's so low. We will continue to monitor it, though.
Lee Shore.
I was wondering if you could put this, what you're doing in a broader context. I was especially interested in whether your very dramatic reductions in the use of seclusion and restraint reflect that you were starting from a higher baseline than others. And also, can you tell us something about other jurisdictions? Are they doing anything similar? What do you know about what is happening elsewhere along these lines?
That's a very good question. One difficulty in answering that is because of the lack of data being published, it's probably difficult to get an exact baseline. But we are confident, based upon our sharing with other state mental health systems, that we were pretty much on par with the use of seclusion and restraint as other mental health systems are, as well as just recently we compared our data to broader state mental health systems around the country and found that we were at this point 100 times lower in many cases. So I think that demonstrates that we were very much on par when you consider a 74% and 96% reduction. And your second question?
Do you know what's happening
and
elsewhere where others are trying to do what you're trying to do?
In fact, I would say state mental health authorities around the country through the National Association of State Mental Health Program Directors, which is my professional association, have taken this very seriously. I've had a focus on this and bringing all the state hospitals together. And I would say, based upon our model, and we shared our model at that seminar, we have received inquiries from many states across the country. State of Wyoming and Nebraska actually are coming in and doing site visits of our state hospitals. So I'm confident state mental health authorities have taken this seriously. We probably have actually had more resistance from the private sector at times in terms of the reduce the seclusion and restraint.
Our time's up, but we do have two additional individuals who'd like to ask questions. David Osborne and then Bill Klinger.
I wanted to go back to this question of treatment outcomes, of the ends you're after. Clearly, this policy is far more humane, and I really applaud you for doing it. But your application says that most of these patients have engaged in behavior that pose significant risk of serious bodily harm to themselves or others. And Dr. Karp said that you now have 85% of them on a new generation of antipsychotic drugs. A lot of things have come and gone in mental health, some of which worked and some of which didn't. There was a day when shock treatment was considered, very successful. Do you have any data on outcomes for patients that really prove that this new policy and the reliance on antipsychotic drugs that goes with it are leading to better outcomes for patients?
Yes, do you want to talk about that?
There's, again, emerging literature. The newer agents have been widely available probably for 4 or 5 years, so the long-term follow-up is still being collected. Clearly, the medicines are at least as effective as the older medicines, and they're much safer, and they are much more, I wouldn't say, I don't know if pleasant's a good word, but the side effects are much less. So we're finding that individuals that struggle with these serious mental illnesses, which are difficult to accept in themselves, are accepting of the treatment much better because the medicines aren't as lousy to take, quite frankly. There's a body of literature that's developing that is demonstrating that individuals, again, are more likely to take and continue to take the medication and require less medical resources as time goes on. Quality of life is improved. But we have not as yet measured those specific, since there's already a body of literature to demonstrate that. We do track our patients to make sure that they're doing well and follow into the community, but we're not currently doing the same type of follow-up.
I might mention in terms of systems outcomes, over the past 5 years, and especially the last 4 years, our state hospital census, average daily census, has decreased from 5,000 to 2,900. And we have tracked those individuals that were long-term as well as individuals who come in and out, and they are living in the community. Our recidivism is less than 5%, which is remarkable compared to several years ago. And bottom line, we're seeing consumers living much more independent, autonomous lives.
Yeah, let me just, I'm a little confused. In response to Ed Doran's question on chemicals, you said they were banned. Are these restraint chemicals that are banned, but in effect you're using antipsychotic drugs or chemicals as a substitute for seclusion and restraint?
No, the antipsychotic drugs are targeted just like a blood pressure pill would be for blood pressure. The antipsychotic drugs are targeted for the area of the brain that's not working right in an attempt to normalize brain function so that the serious mental illness symptoms come under better control. Chemical restraint, as we define it, would be the use of a medication, basically a sedative that would make somebody unresponsive and unable to carry out their activities.
Yeah, I think bottom line...
Is that clear to you, Ed Doran?
Well,
I'm sure it's clear to them.
yeah. Well, I was going to say the new...
It's not to me, but I'll accept that there's a distinction.
The new antipsychotic medications do alleviate the symptoms of mental illness. Some of those symptoms relate to aggressiveness and that type of thing overall. A chemical restraint is applied at the time someone is aggressively acting out, so to speak, and is controlling their behavior at that moment. It's like a tranquilizer that restrains them perhaps makes them zombie-like in the past, and we do not allow that. Medication is part of their treatment regime, which actually affects the symptoms of the illness in a positive way.
And in fact, the sedation would be considered a side effect, and we don't want that to happen in the treatment when we're using the new medicines specifically for treatment, if they are sedated.
So other jurisdictions will be using the same antipsychotics?
Yes, absolutely, absolutely. And there are people today who we would have said a few years ago would have spent the rest of their lives in a hospital setting, who because of the new antipsychotic meds, it's given them a major start in eliminating the voices, eliminating the devastating moods, and helping them be able to focus once again and be able to live a life like we want to live.
Bill Klinger, did you still have a question?
Yeah, just very briefly, you talk about changing the culture and that's a big undertaking to change an entire culture, and it obviously depends upon the quality of your workforce and how committed they are to this. How did you do that, and what sort of educational process did you go through, and how do you ensure that the new people coming into the system, that is, new employees, are brought up to the standards that you expect of
We'll
the
both
employer?
briefly answer that question. Overall, the basic innovation or reframing here, that seclusion and restraint are not treatment interventions, are not normal operating procedures, was, I think, a critical reframing. And I think the process of how we did it in Pennsylvania is as important as the policy. It was over a period of years that we worked with our staffs, and we used people who were actually practitioners at the front line in developing our policies and approach through all of our state hospitals, up through management. So there was much ownership over a period of time. This started in late 96, 97. I did not sign the policy until January of 99, once we had honed that further and knew exactly what we were doing. And so I think that's been a major help in shifting that culture over time. And there was resistance, and still continues to be some pockets of resistance that we're working with, because there was a concern that people felt something was being taken away from them, a tool that they had been used to. And in terms of training ongoing, Steve?
Well, the other piece is that brain science has exploded in the past 10 years and 30 years. Again, our treatments are much more effective than they were 10, even 20 years ago. And the culture of psychiatry, that's a whole lecture in itself, if you will, the history of psychiatry, but there was a time in the 1800s where chaining somebody to the wall was the only way that you were going to effectively reduce the dangerousness to themselves or to others. So interwoven into, even though medical professionals are humane and they don't want to induce suffering in an individual, the history and the culture of psychiatry is that was at one time one of the only tools.
Well, I might mention also that training is critical. We have ongoing staff training, right, new orientation for new staff, and training is central.
Ed Psyche?
And isolation in law. Are you attempting to pursue that in your legislature?
No, we have not pursued that specifically. I do know that there has been recent federal legislation which does put some clear guidelines around the implementation of seclusion and restraint. I think what we see ourselves doing is honing our approach, educating others, helping it become replicated, and over time, I guess we'd see if it makes sense for it to be put into law.
That'll change the culture real quick.
Very quickly.
And how about your private facilities?
We have a draft bulletin out right now in which we're getting feedback from providers throughout the Commonwealth of Pennsylvania, because we also license psychiatric facilities, and the guidelines are very similar to our guidelines in the state hospital system. So we are looking to issue a bulletin around those guidelines, hopefully in just the next few months. And we have been sharing what we've done in the state hospital and trying to be a technical assistance resource to the private sector as well.
All right. Mr. Curry and Dr. Karp, we thank you both very much for coming here.